And then 3, 2, 1 here.
Are we ready?
Yeah. Yeah. That's right.
Hi, everybody. Welcome to Mad Chaos Fertility Factor Fiction. We are still trying to integrate multiple technologies into one streaming service. So it's a little bit chaotic if you're watching us on TikTok. We are trying to integrate TikTok with a video camera into a multiple platform distribution service, and it's not working out so easily. So thank you for joining on all of the different platforms. We did have a brief live show on Sunday, right? Yeah, on TikTok, answering some of the questions from before. Thank you to all of you who joined. Tarek and I are kind of partial now to TikTok because we put up that silly little video of me gesturing at something a doctor was saying, and over 1 million people have watched it. So we are in love with TikTok a little bit, and our YouTube. We still post on Instagram and Facebook and Twitter. So I am your host, Dr. Rahi Victory. If you have not joined us before on the show, thank you for joining us tonight. I am here as a reproductive endocrinology and infertility specialist, and next to me off camera is my dear friend Tarek Ibrahim from the Ibrahim Strategies Group. And he was having an all-out conniption a few minutes ago because it was chaos trying to get this up and running. But we're good now. So welcome to tonight's show. So we are working on a new video for talking about patients that have a thin endometrium. And we're going to have that video out shortly. But in the meantime, a new article is coming out which talks about the opportunity to actually stimulate someone using gonadotropins like Gonal F, Menopur, that kind of thing, to thicken the lining. Now, years and years ago, I actually tried this, and it does work well, but the problem with it was that there were a lot of studies that said that we need to be careful that you not kind of overdo it, because if you get estrogen levels that are too high, progesterone levels that are too high, it can kind of gum everything up, and then you actually have decreased your chances instead of increasing them. And I do remember a study, which I have not been able to dig up again, unfortunately, that said actually it was a bad idea because it reduced your success rates. So along comes a new study which says if you have persistently thin endometrium despite estrogen administration, can you try stimulation for those patients to see if they will benefit? So I thought, well, let's give this a read. And actually, the results are kind of interesting, so I want to share those with you. It's a little bit of a difficult article to read, and I can't show you all the information because when they sent out the pre-publication proof, they actually sent it out with not all the information displayed. So I don't have every single bit of data for you, but what I do have is kind of interesting and might apply to a lot of you. So let's just talk about thin endometrium for a minute. When you're doing an embryo transfer, your lining of your uterus, the endometrium, must thicken sufficiently in order to be able to accept an embryo. What's sufficiently? Well, nobody agrees exactly on what's sufficient and what's insufficient. Some people say 7 millimeters, some people say 8 millimeters, but at the end of the day, we think it's somewhere between 7 to 8 millimeters as your kind of ideal minimum criteria for a successful implantation. So 7 to 8 millimeters, and if you ever see what it looks like, T, you're gonna have to let me screen share, buddy. So if you ever see what it looks like 3 kind of lines on the ultrasound. So I'll show you that in just 1 second as we connect to the camera here. Yep, that should be good. Oh, you know what? I'll have to jump into a different. Yeah, let me go into this one. Nope, wrong one. Sorry, guys. There we go. So this is what endometrium looks like. So if you look right there, so you can see the 3 lines. And for those of you on TikTok, you won't be able to see this. Sorry. I can probably show you on the screen. You can see that there are 3 lines there. And those 3 lines are the basalis and the integration between the 2 basalis layers where they meet in the middle. And those are all the layers of the endometrium. So when it's less than 7 millimeters of thickness, that is definitely a problem for us, because that indicates that you can stop sharing for a sec, that not everything is perfect and that you're not getting a thick enough lining. So typically in the past, what we always did was give estrogen. Now, estrogen will work to a point, but it depends on the reason for why you have a thin lining. If it's from scarring, if it's from Asherman syndrome, if it's because there's a hormonal problem, estrogen is not necessarily going to work. So if you have scarring inside your uterus and the 2 layers are stuck together, you can pump in all the estrogen in the world. The ability for it to separate is going to be limited by the scarring, which literally actually holds the 2 layers together. So that won't work. Other people have other abnormalities that are causing a problem for the thickening. And in many cases, it's actually unexplained. We don't know why their uterus won't thicken. So the various things that have been tried and that we still use. So some people use high doses of estrogen. That's perfectly fine. Some people are using PRP, which we are starting to use now, and we're finding some pretty decent results with that. Neupogen or GM-CSF has been tried. People have tried vitamin D, vitamin C, vitamin E, vaginal Viagra, baby aspirin, pentoxifylline. There's a bunch of different approaches to this, and sometimes we use a bunch of them, sometimes we use some of them, but they're all legitimate approaches. The problem with using high dose estrogen, as I mentioned, is A, it doesn't always solve the problem, depending on what the source is, and B, you don't want really high levels of estrogen, because we know from other studies we've presented to you guys on the show that if you use a really high level of estrogen, it's probably detrimental to your success rates. So these guys said, well, what about in that select group where you've tried estrogen and it's not working? What if you stimulate those ones? So I thought I'd share that study with you. So this is a retrospective study. It's from China. They looked at the cycles that they had done, and they essentially took 627 patients who did 683 frozen embryo transfers. All of these were people that at least at one point had had a lining that they considered thin, which they defined as less than 7 millimeters of thickness. And they had gone on estrogen for at least 21 days with no result. So if they went for 21 days on estrogen and they couldn't get a thick enough lining, they said either you cancel or you transfer, or you start our new protocol, which is we're going to put you on progesterone, we're going to induce a bleed, we're going to stim you with stimulation medication, and we're going to see when you get to the right thickness. And the minute you hit the right thickness, we're going to start your progesterone. We don't care about the eggs, and then we're going to go ahead and transfer. So we'll go through a couple of criteria here which were important, okay? So number one, they defined it, like I said, as 7 millimeters, which is really important. The patients had to have at least one episode of a thin lining in a previous attempt at an FET or during an FET, and the patients had to be less than 43 years of age. Who did they exclude? If you had moderate or severe endo, you were excluded. If you had severe adenomyosis, you were excluded. If you had a hydrosalpinx that was untreated, you were excluded. If there was a fibroid or a polyp or an adhesion in the cavity, you were excluded. If you had a lot of large fibroids, more than 4 centimeters, you're excluded. That's actually good criteria, because if your fibroids are more than 4 centimeters, regardless of where they are, they can have an impact. And certainly if you had a problem inside the cavity, as well as anyone with a hysteroscopic abnormality, scarring, adhesions, any kind of problem like that. If they had PCOS, they kept them in. Most PCOS women don't have thin linings, but it has been reported before. Okay, what did they do for their endometrial preparation? So this is really critical. So as you guys know, if you watch our show, we are huge proponents of not doing an estrogen stimulation protocol, because it actually yields the lowest chance of success. These guys are actually using the estrogen stimulation protocol, but it's still important because it is going to give you a thicker lining than many of these other protocols we use. So if that's not working, then definitely you're going to need something additional. So what did these guys do? From day 3 to 6 of your menstrual cycle, you got 3 milligrams of estrogen twice a day, and that was oral. And then from days 7 till 11, or 10 or 11, you used 4 milligrams twice a day. And they assessed it with transvaginal ultrasound. If your lining was less than 6 millimeters at that point, they gave you 2 milligrams of micronized estradiol per day, which I'm assuming was vaginal, and that's what they reported, for another 5 to 7 days. So this is like getting into a pretty long stimulation protocol for the estrogen part of things. They were allowing the vaginal estrogen to then go up to a maximum of 4 milligrams twice a day, and extended it up to 14 to 20 days, at which point they did a final ultrasound. If at that point you still weren't 7 millimeters, you either canceled, or you went ahead and did your transfer, or you switched into this new protocol. New protocol, continue all the estrogen, throw in some progesterone to stabilize everything, have a period, and then start on your gonadotropin product. Once you were on the gonadotropin, you took shots, they brought you in and monitored you. Once you hit 8 millimeters, they then said, okay, you're good now, and we're gonna fire ahead with the embryo transfer. So they started the progesterone, and 5 days later, they did the progesterone. I am quite proud of their study protocol because they used double progesterone. They used an injectable version, and they used the vaginal version, which is what we do. So I like this because it's very close to what we're doing. They used the right technique for ultrasound to do their measures. And then what were their assessments? They looked at pregnancies. They looked at clinical pregnancy, which they kind of missed the boat on because they just considered it a sac instead of a heartbeat, but that's okay. And then they actually looked at live birth data as well. So I'm going to read you some of the results because they're really critical to hear about, and then I'll show you on the tables that they included. So in the group that had the gonadotropins, the dosage was given for about 11 days on average. So you are taking shots for quite some time. So keep in mind, there's a cost factor in here. And they were giving them roughly about 200 units, 150 to 200 units per day. So that's a fair amount of cost. So you're looking at minimum somewhere around $2,500 worth of medication. 220 patients, 249 cycles were canceled, so they just didn't make it. Reasons for cancellation included high progesterone levels, insufficient estrogen production due to poor ovarian response. That was only 7 cycles, so 2.8% of people. Fluid in the cavity, that was 2.8% of people, and thinner lining than they had previously seen. And so finally, they had 185 patients who underwent 213 cycles using that HMG protocol. So some people were excluded, quite a few, because they just didn't make it, okay? And that's important to know. So out of all the 235 cycles that they had, 80.95% of the cycles, which was 187, got a thicker lining with the gonadotropins than they did with high doses of estrogen, which they were using before. And they call that intensive estrogen application. And in total, 62.3% of the cycles reached a lining greater than 7 millimeters. 20.78% reached a lining greater than 8 millimeters, which is really good because that's our target. So pretty impressive data there. So I'll share some tables with you. So T, let me get to the table. Yep, you can screen share there, and I'll just blow that up a little bit for everyone to see. We're on? Okay, so again, TikTok folks, I'm sorry you can't see this, but I'll read the numbers out to you. So if stimulation, your lining was less than 6 millimeters. The mean, it was only about 5 millimeters. If you were between 6 and 6.9 millimeters, you're at about 6.3, which is not too terrible. It's reasonable to have a 6.3. What was it after they gave you the stimulation? It went up in the group that was less than 6 millimeters to 6.67, showing a mean increase of 1.67. And in the other group, it went up to 7.44, which was up to 1.15 millimeters higher than it had been previously. So these are getting you closer to that 7 millimeter, 8 millimeter range. And again, these are averages, so some of the patients were getting into the appropriate categories. If we jump into another table, which is down here, and here's where some of the data is missing, unfortunately. If you were less than 6 millimeters, your clinical pregnancy rate was 44.4% in the group that got the gonadotropins versus only 6.9% in the group that didn't. So that is an enormous, enormous difference, right? Huge, huge differences here in the outcome. Implantation rate, 29.5%, which admittedly is low, but these are obviously problematic patients, so it's not terrible either, versus only 3.7% in the intensive estrogen group. Huge, huge differences. I mean, we're looking almost 10 times difference there. So very, very significant findings. What about the live birth? 37% versus only 6%. So again, almost a 10-fold increase in the rate of live birth. So these numbers are huge. I mean, they're staggering. You can stop screen sharing. The rest of it wasn't hugely important. So very, very critical data. So what does this tell us? Well, if you have a thin lining and we've tried all the other stuff, it actually might be reasonable to go back to doing a stimulation. Is it cost effective? Well, if you have drug coverage, it's very cost effective. It'd be cheaper than doing the PRP and the Neupogen and all that other stuff because people don't have coverage for all of that. If you don't have coverage, then that's a different story. And you'd have to kind of look at it and see, you know, is it worth it for me to spend $2,500 on the meds, or should I try the PRP and the Neupogen, which, at least in our practice, is much cheaper than that? So there are some questions about the financial viability of this, but for those of you who have drug coverage, it might be a really reasonable thing to consider if your lining is very thin. And I'm super excited about it because definitely the old data said to us that this was not a great idea, but maybe in certain cases, this might be worth looking at again and trying to see for some of those patients where we just can't get their lining to thicken, will a little bit of ovarian stimulation give us the best natural response, getting your body to do what we want it to without having to pump you full of a ton of other adjuncts, therapies, and high doses of estrogen, which you don't want to do. So that is fertility fact or fiction for this week. We're going to do some live questions now, but is it a fact or fiction? It actually looks like it's a fact that stimulation can improve the thickness of your lining and get you that much closer to that, you know, perfect number. I think Tarek probably has a litany of questions for us, and we're going to take all those. If we don't answer your question right away, this is a full disclaimer, guys. Don't jump on 5 other platforms to ask the same question. He does go through them one by one, and he will happily answer all the questions or ask all the questions so that I can answer them. But don't jump platform to platform because then we just reread your same question again, and it takes away from people's time to answer their questions as well. So just stay on one platform, ask away. We will answer your questions as we get to them for sure. And if you have a chance to invite others, please do. Anytime you throw up likes, it helps us get more people involved. So we like that too. So thank you for watching that part of the show. Fire away.
What up, boys?
Is that what it says?
That's how it started.
That's good. I like that.
Hold your horses, big part 2 question.
Okay.
Part 1.
Okay.
One failed FET.
Okay.
Did a
Polypectomy.
Gained weight as per your recommended banana split diet.
Oh, excellent. Yeah, I love that.
BMI now from 18 to 19.5.
Okay, good.
A game on vitamins and supplements.
Okay.
3 embryos left.
Okay.
If my next transfer fails,
Yeah.
when would it be time for a recurrent implantation failure workup? What tests would that include?
Ooh.
And there's still a part 2.
Okay, wait, let me answer that one first. So recurrent implantation failure, we would do thrombophilia screen, sperm DNA fragmentation, check all your vitamins, make sure you've had a saline infusion, sonohystogram. We do fertility testing, and making sure that your embryos are genetically normal is a big part of that as well. assuming we've got all of that, we usually find enough. We also do a very advanced thyroid panel, including your antibodies. So that would be the majority of the things we are looking at. Okay?
Part 2. Thoughts on my upcoming transfer natural cycle FET. Aspirin day 1,
Yeah.
day 12.
Okay.
Ultrasound 18 millimeter follicle, lining good, overdrill.
Okay.
Day 14 endometrium, day 18 3 times embryo transfer and prog blood test, day 21.
So we do things differently, but that's a reasonable approach to things. The key is making sure your progesterone level doesn't overshoot, because you took Ovidrel, which is going to cause your egg to release, which leaves you with the corpus luteum. That's going to produce progesterone. So if you're producing progesterone, you could overshoot where you want to be, and now you're kind of on birth control if you're taking progesterone and you're producing natural progesterone. So just get your levels checked earlier. Aside from that, that seems like a fairly reasonable protocol.
Thank you, Tarek, for reading out this long-ass question, and thank you, Dr. Victory, for answering.
We got one from Me. Remember Me? She
Yeah,
watched
I
us the
remember
other
Me.
day. Hi,
Yeah.
Me. Coolest name ever on TikTok. Is there any evidence that having had COVID could affect your fertility? Zero. From the standpoint of women, it does not affect anything if you've had COVID. For guys, it can significantly alter your sperm performance. So for the guys, it can be a problem. And if you're male, you can anticipate that there may be a brief decline in sperm performance. It does bounce back to normal, but there can be some decrease in sperm performance, in particular if you had really bad COVID, high fever, that kind of thing.
Hi, rock stars.
Rock stars.
Dr. V, what are your thoughts on prog supplementation on a natural cycle? My OB doesn't believe in it, but mine has been low. One cycle pod 7 was 7, and another cycle pod 6 was 6. Had a loss at 7 weeks on prog sub, and she said it keeps a bad pregnancy going. 2 cycles after loss, 2 chemical pregnancies. I'm 40 with DOR.
Well, the problem there is no one's going to be able to answer for you if your issue is a genetic issue or if it's a progesterone issue. Do I believe in using progesterone for people with low progesterone levels? I do, actually. Now, the studies don't actually support that, so I want to be very clear about that. Studies do not support using progesterone in natural cycles for people just conceiving on their own. But if your progesterone levels are that low, I actually would advise that you use it. Having said that, always remember that if the main issue is coming from the fact that your embryos are not genetically normal because of either the DOR or your age, unfortunately, that the progesterone is not going to solve that problem. So the first thing to know is, are we dealing with a genetically normal embryo, which you can only figure out from IVF? And then if you are dealing with a genetically normal embryo, how do you determine if it's the progesterone? Well, if it's a genetically normal embryo and you're still miscarrying, it's probably something going on there. Progesterone would be one of the first things we would look at. And certainly if it was an embryo transfer situation, you want your level higher than 6 or 7. So that's important.
Do you recommend PGS testing of embryos for someone who is 35?
Okay, so full disclosure, nobody knows. If you talk to some of the world experts, they say abandon PGT. There was another recent study that showed that from England that showed that it was totally useless to do PGT. There's no benefit to it. In fact, in that study, it showed that it decreased the overall success rates. On the flip side, if you talk to some other people like Richard Scott, who is one of the smartest people in the fertility world, there is absolutely no question that he is the strongest proponent of PGT and swears up and down that it improves it. I spoke with one of my colleagues last week. We were discussing it, and he said he does it for almost everybody and he's getting phenomenal success rates. I mean, it kind of makes sense, because if you're doing PGT on everybody and you're only using normal embryos, well, of course, it just makes sense that those embryos are going to have a higher chance of success than people with untested embryos, right? So you are excluding a whole trainload of people who just don't have normal embryos. So yes, you're artificially inflating your success. The question is, do we have a really good randomized controlled trial comparing no PGT to PGT, kind of in all comers, like real world clinical application, while you're controlling for everything? And the answer is we don't. So no one knows for sure. So we were saying 38 and above, definitely, just because statistically we know what the percentage of abnormal embryos is. You're looking at about somewhere between 2/3 and 3/4 of that stage being abnormal. And so with that in mind, we were advocating for doing it at that stage. When I came back from the conference from Denmark, we kind of moved it down a little bit lower, but we're still leaving that as a gray zone. So sort of 35 to 38, we're telling patients it's kind of up to you. Less than 35, I'm kind of hard pressed to see what the value of it is yet, although Richard Scott said 30 or 32. So no one knows for sure, guys. It's a great question. I'm praying that someone comes out with the answer. We just don't know yet.
How long should you stay on Plaquenil if you've been on it
Whole
upon
pregnancy.
getting pregnant?
Stay on it. Stay on it for the whole pregnancy.
Do you think it's worth doing reproductive immunology testing after one miscarriage, or is that something to do after a second one? I was looking at Fertility for testing. What do you think of that testing?
You know, I should have invested in Fertility.
We
pretty much
do it.
single-handedly made them famous. You know what? I wouldn't do Fertility testing or any testing for that matter after just one miscarriage. That's a lot of investment, time, energy, thought process, emotions, all that stuff. If it's just one natural miscarriage. Now, if you miscarried a euploid embryo, that's a whole other discussion. So if you did an embryo transfer with a genetically normal embryo and had a miscarriage, yeah, that's a discussion I'm willing to have. But aside from that, no, I wouldn't be doing that. Me asked, I've had 3 children without assistance. I am overweight, but the same weight as before I've been. I'm not sure if there's a question there, me. Me, ask me the rest of that question. Cystic for years, but now having problems with conceiving. Oh, I've been cystic for years, but now having problems with conceiving. Is this just age? What could contribute? Lots of factors. Vitamin levels, weight is a factor. It definitely can influence things. Age is a huge factor. It's the number one factor. Your partner's age, your partner's sperm quality, smoking, drinking, drug use, all sorts of different things. If you had cesareans, that can influence things too.
Is it normal for symptoms to come and go in the first trimester? Thank you.
Yeah, we as OBGYNs never put any stock in your symptoms. You know, I was flipping through YouTube the other day and there's like videos with millions of hits for people that, thought that they could tell if they were pregnant based on their symptoms. You can't. So some women have nothing and other women are like exhausted and puking days after they're pregnant. It's just not possible to say it's a, one application to everybody. Every woman has a different pregnancy. So there is no sign or symptom that is particularly helpful. Now, certainly, if you're puking all the time and you're sick all the time, it's probably a good sign that you're still pregnant. But the absence of feeling queasy or vomiting or nausea, that probably has, very little value. So if you have symptoms, sure, it might indicate you're pregnant, but not having symptoms doesn't mean you're not pregnant. Or that there's a miscarriage or a problem or anything.
Dr. V&T, I got a positive first beta after taking letrozole in natural cycle. Beta was 536. Now to wait for the second one.
Okay.
And they're just sharing excitement.
Oh, excitement. Yay! Congratulations. That's great. We always love the good, happy stories. So that's incredible. Good for you. Congratulations. Lots of thumbs up and hearts and likes and whatever. What is the symbol for a like on TikTok? I don't know.
Heart.
It's more hearts?
Someone was throwing soccer balls not too long ago. I was wondering what that one is all about.
I have no
But,
idea.
I'm down. I'm
All
down
right.
with the soccer
Well,
ball.
lots of thumbs up and likes and hearts and whatever else we're supposed to throw at you. Lots of baby dust. That's great.
Dr. V and T.
Yep.
I got a positive first beta after taking letrozole. Oh, sorry. Dr. V and the alluring T. See, this is what I'm talking about.
Woo!
These are my people.
Yeah, I'm gonna have to find something sharp to deflate you with. Yeah, I got it. All right, here we go.
There we go. There we go. That's actually pretty sharp.
Yeah, it's very sharp.
That'll do
yeah.
it. That will actually do it. Dr. V and the alluring T.
Uh-huh.
I read it again.
You needed
Yeah.
to repeat that one.
Yeah. Is it normal to have light spotting
Yeah.
in 14 DPT with a beta of 199? Should I be worried?
Well, spotting's never great, so that's a little concerning. So yes, I would, if you're on anything that causes bleeding, aspirin, heparin, talk to your doctor. We normally recommend stopping, but talk to your doctor. I don't want you stopping anything without knowing your history. Yeah, I mean, it's cause for concern, so make sure they're doing serial betas every 48 hours.
Hi, Dr. V and T. Trigger warning.
Uh-oh.
I had a miscarriage at 6 weeks.
Oh, I'm sorry.
What do you suggest I do or add to help that not happen with our next embryo transfer?
Oh, I need to know so much more about you, right? So miscarriage can be caused from, number one, genetic problems with the embryo. It can be caused by paternal factors, poor sperm quality, paternal smoking, drinking, drug use, high DNA fragmentation. Maternal factors, all those same things, vitamins, weight, problems with the shape of your uterus, polyps, fibroids, infections, immunological problems, thrombophilia. There's like a huge list of potential sources of miscarriage. So I need to know a lot more about you. I would be happy to help you out, but you would need to let me know what's going on with you, and then we can chat with you about it.
Hi, Dr. V, and my favorite tea.
Oh, favorite tea. That's very cute.
Thoughts on dexamethasone before retrieval for elevated T and DHEA?
Dexamethasone is great. There's actually good studies showing that dexamethasone in your IVF cycle improves your outcomes. So, and we reviewed that on the show a while back. I've got all the data, but yeah, there's no question dexamethasone is a good thing. So if your fertility center is using it, they know what they're doing, at least for that part. So yeah, I support it for sure.
Hi, T, with nice big red heart.
A big red heart, yeah.
Yeah.
Okay.
And then they wrote, and Dr. V.
And Dr. Yeah, I'm just like the afterthought
Yeah,
there.
yeah. No heart, no smiley face.
Thanks for that, yeah.
Just so you can imagine it. 'Cause I know you don't see it.
Yeah, did you want some lemon for the paper
No,
cuts you're
no,
giving me?
no, no,
Okay, all right.
we're
Just
good.
want to squeeze a little bit in there.
We're good.
Yeah.
We're good. Should I read it again? Or you got it?
No, I got it. Yeah.
My embryo grading were day 5 and 6 BB.
Oh, okay, those are good. Yeah.
Is there any way to improve the quality to AA? Thanks. You two are awesome.
Okay, so if you're talking about improving the quality with an existing embryo, no, you can't change the quality of your existing embryo. Although there's some evidence that thawing it in media that contains neupogen can be beneficial. But otherwise, no. But if you're talking about making new embryos, there's loads of things. Neupogen media, making sure you're on all the right vitamins, using the right stimulation with not high doses of medications, triggering with a double trigger, human growth hormone, DHEA, testosterone priming, those are all useful. Really good lab, optimized ICSI, time-lapse incubators, all of these things have been shown to improve embryo quality, so any of those are useful. Hey, check this out. Hello. I was one of your patients. You delivered my first son 10 years ago.
Man, so
That's cool, man. Yeah. Yeah. And I don't recognize that flag. Which flag is that? I'm terrible with geography and flags.
That's Palestine.
That's Palestine.
Palestine and proud.
Pally and proud. I should have
There you
known
go.
that.
There you
Yeah.
go.
Well, I got the right guy for.
Yeah.
figuring out if it's an Arab flag. That's good.
We
Yeah.
can catch those.
Yeah.
High T. And Dr. V.
And I'm not, yeah, just the afterthought.
Afterthought, yeah.
Yeah.
Does taking progesterone,
Yeah.
endometrium twice a day,
Yeah.
make you nausea and vomiting worse? I'm 11 weeks, 4 days.
No, not at all. Progesterone, generally speaking, doesn't have any association with your nausea. Estrogen levels do, but not the progesterone levels. I literally just told them about it while we watched this, LOL. Well, thank you, Pally and Proud. That's really cute. Told the 10-year-old. I love it.
Hi, Dr. V and T. What supplements do you recommend to prep for FET?
Vitamin D, fish oils, your prenatal vitamin, iron. Those are the basics. And then melatonin as well, and baby aspirin, which isn't really a vitamin or supplement. It's a medication, but all those are really useful. In terms of something more than that, it depends. So if you have PCOS, we use NAC, inositol, coenzyme Q10, and resveratrol. And if you have endo, we switch out the inositol and we put in curcumin. So all of those are reasonable approaches.
Hi, Dr. Victory. Anti.
So
Okay. So you got.
It was
something.
Yeah. Mm-hmm. I'm wondering about which questions you're selecting now, but anyways.
These are good questions to ask. You understand my process.
Yeah.
What are your reasons for cancellation of an FET at your clinic? I have transfer on Friday with you, and I am a little worried.
Oh. So if your lining's too thin, we wouldn't do it. If we can't get through your cervix, obviously we wouldn't do it. If your progesterone levels are way too high, we wouldn't do it. That's basically about it. There aren't a whole lot of reasons why we would cancel an FET. And we're so meticulous about our monitoring. I don't think we've canceled that many FETs, to be honest with you. It's like a handful ever. Usually we know well in advance whether or not you're going to get canceled or not.
Are there any tips for tonight that you can give me other than getting a good night's rest?
What's happening tomorrow? Same person or someone else?
This is, I think just
in general?
Just in general.
Any tips? Have
tips?
sex and get a good night's rest. Yeah. I mean, ejaculate helps prime the uterus, helps you get pregnant. So have sex, relax, don't smoke, don't drink, don't use any drugs. Do some yoga, meditate, stay as calm as humanly possible. So somebody else jumped on and said, I watched you deliver my nephew. And then Pally and Proud jumped on and said, LOL, that's my sister.
Man, it's a whole family. It's a whole reunion happening on here.
That's awesome. Well, thank you guys. It's good to have you all here. I'll give you his B-Day to remind you, May 11th, 2012. Very cute.
There you go.
Very cute. All right.
Hi, Dr. V. I had a lighting check yesterday, and it was 9.45. My
awesome.
FET is next Monday. Will it be too thick? What measurements is considered too thick?
Probably not, because by the time you start your progesterone, it starts to compress. So 9 is fine. I don't get nervous about that at all. If you're over like 12, 13, we start getting nervous, and those are ones where we will cancel. But otherwise, no. You're all good.
Is HGH priming, such as Omnitrope and Sazin, being used more for DOR and or egg quality? Run retrieval and ended with no embryos. Eggs looked stressed in this case. Would Recavel be any further preferred over Gonal-F?
So we do use a lot of Recavel in patients that have DOR. I'm a believer in that situation. I love Gonal-F, but I do use Recavel a lot as well. So it may be beneficial. And there is biological plausibility, meaning believability, behind the theory of why Recavel might be better for some people. That's a reasonable approach. Human growth hormone has been shown to increase the number of embryos, number of mature eggs, and even the embryo quality. So those are all reasonable reasons to try it. I would need to know more details about you, but it's certainly worth considering. Yeah.
In the event we get to that point,
okay,
Can you explain how the process would work if we used a blood sister as a egg donor? Egg retrieval would be completed on her, then the transfer would set up to me?
Yeah, that's exactly what happens. We have loads of people that do that. So they come in with their sister. The sister is going to be the egg donor. So we test the sister. We make sure she's perfect. We have to do genetic testing for her, genetic testing for your partner, make sure everything's a good match. Assuming it's all good to go, we stim your sister. She produces all the eggs. We retrieve from her. We take the eggs, we turn them into embryos with your partner's sperm. Once we've got the embryos grown, we can try and aim for a fresh embryo transfer into you if we can line the two of you up. If it doesn't work, no big deal. We freeze them, we bring you back, and we're good to go from there. Sorry, folks. Yeah.
You're still good?
It's coming back, yeah. Yeah.
Where are you guys? What are you guys expect to see in the first U.S. after successful beta 2 for FET?
What are you expecting to see in the first ultrasound after what?
After successful beta 2 for FET.
So it depends on what time they do your ultrasound. I mean, at 6 weeks, you'll see a sac, you'll see a fetal pole, and you'll see a heart rate. Yeah, any of those would be reasonable.
Hi, Dream Team.
Oh, hello.
Can't be mad at that intro.
No, you can't be mad at that.
I like that one.
Yeah.
It's not a direct T compliment, but team is a good spirit. I don't get angry at the team.
Yeah.
Failed medicated FET with PGTA normal embryo.
Failed medicated FET? Okay, yeah.
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 BHCG.
Beta HCG.
569 and then 1732.
Oh, I'm sorry.
Developed SCH.
Septorionic hemorrhage.
7W3D.
Okay.
Ultrasound showed no heartbeat.
Okay.
Had a DNC.
Okay.
Testing product of conception. Any recommendations for the next FET? Thanks.
I mean, and she said it was a euploid embryo. It was PGT tested, right?
Yeah, PGTA. Normal embryo.
Yeah, I mean, those are the cases where I want to know what's wrong. So I would want to know about your immune system, the possibility of adenomyosis, endometriosis. I'd want to know if there was anything else going on there. I would want to know if there's a problem with the sperm quality. Does he have high DNA fragmentation? Is he a smoker, drinker, drug user? Are you doing any of those things? Your BMI is really important. Like, there's a lot of factors that go into it there. So, yeah, all of those things would be important for us to consider.
How does doing the stim affect the endometrial receptivity?
How does doing what?
Stim.
Oh, yeah. So if your estrogen gets too high or your progesterone gets high, it'll completely screw up your endometrial receptivity. That's why I read that there are some cases that did get canceled because of that. So it's important to know the limitations of this, but used properly, it may actually be beneficial for you.
Hi, Dr. VNT. Should I avoid scents even after my FET or only before and during the actual procedure?
You should probably avoid it in general. Yeah, I would. Pally and Proud has a question. I have a question about birth control. I have not taken any form of birth control in years. What do you recommend for a woman in her late 30s for birth control? You can use any kind of birth control pill, as long as you don't have any contraindications, high blood pressure, smoking, that kind of thing, or significant obesity. For the patients that do have risks or don't want to have to take a pill, the IUD is a great option. There's two kinds. There's one with progesterone, one without. They're both reasonable choices. So either of those is good. Pally and Proud as a smoker, stop smoking. Absolutely stop smoking. You cannot smoke. Smoking is terrible for you, so stop smoking. And don't take the birth control pill with smoking because there is a higher risk of heart attack. So then you have to take an IUD. But stop smoking. There's lots of ways to quit. She's saying I'm right. I know I'm right. Stop smoking. Yeah.
That's great.
It's really like live, eh? Like
Yeah,
real
yeah,
time.
real
It's
time.
kind of
Yeah,
cool.
yeah,
Yeah.
yeah. Hi, Dr. V. Can you walk us through a modified natural transfer with letrozole?
Yep. Take your letrozole day 3 to 7. Wait till your lining thickens, start double progesterone, and go for your embryo transfer. That's pretty much as easy as it is. You don't need to trigger the release of the egg. You can just go on your progesterone. We measure the progesterone levels after 3 days. Aim for your embryo transfer. We do throw in a lot of adjuncts, so aspirin, melatonin, vitamin D, iron, your fish oils, your prenatal. We use antibiotics and then probiotics. So we have a lot of tweaks to our protocol, but the basics are simple. Take your letrozole day 3 to 7, monitor the thickness of the lining. As long as you hit 8 millimeters before you release your egg, and it has to be before, then you start your progesterone and you're good to go.
Hi, Dr. V. Optimal ferritin levels. Also, what are your thoughts on DHEA?
Optimal ferritin levels outside of pregnancy are relatively high. You want it like over 100. And what are my thoughts on DHEA? We use DHEA all the time. It definitely works. We've got a video on it on our YouTube channel. DHEA has been proven to be beneficial. So someone's asking if we, oh, it's Pally. Pally's asking if we have moderators. No, Tarek and I have barely a filter, let alone a moderator. Lex, hey, we've got Lex. What is your opinion on metformin for helping PCOS? It's wonderful. So for people that have insulin resistance, metformin has been proven time and time again to be beneficial and should be incorporated, but by itself, it's probably not enough. So we use it with letrozole. It's very synergistic together. And then on top of that, we use lots of supplements, and then we add in lifestyle changes. So I'm not a believer in go lose weight or just take letrozole when it comes to PCOS. We tell people that there's a 3-pronged approach, or the trident approach, I guess you could call it. I should coin that, the trident PCOS approach. So number 1, you have to take meds, which are letrozole and metformin if it's indicated for you. 2 is the natural supplements, so NAC, inositol, coenzyme Q10, and resveratrol. And then 3, lifestyle, if you fall into the category where weight is a bit of an issue. So low calorie diet, very high protein, low carbs, 6 times a day, and then exercise. And it's really, really critical that you follow all 3. Telling women to just go lose weight is, quite frankly, ignorant, and we never do that. We work with our patients to make sure they understand the risks, the benefits, and what's actually going to help them.
What are your thoughts on a blighted ovum?
Well, aside from the fact that it sucks, we don't know what causes blighted ovums. So no one's been able to figure that out yet. Essentially, it's an anembryonic pregnancy. So you get a sac, but no embryo developing. We don't know. It's probably just early failure from a genetic cause, but no one knows.
Can I wear makeup for my FET?
Yeah, as long as it doesn't have a strong scent, and it shouldn't, you can wear makeup to your FET. But I take all my patients, no matter what they look like. You're all beautiful, so don't worry about makeup. You can come in looking like whatever you want to look like.
There you go.
Yeah.
That's nice. Good spirits.
Yeah, that's the right way. What was the last supplement? Resveratrol. Resveratrol. Resveratrol.
What about a tugal ligation? How hard is it to reverse that?
It depends on how they tied your tubes. So if they tied your tubes with a clip, a Filshie clip, which is this little tiny thing, it's super easy if you're a good surgeon. The stitches are so fine that you need special magnifying glasses or a microscope to operate because they're hard to see without the scope, but otherwise it's fairly easy as long as you're properly trained in microsurgery, because it's microsurgery. I mean, the tubal lumen is very, very small. If it's been burned, it's quite difficult and it doesn't work very well. If it's been partially removed, probably very difficult, not always. Sometimes we can still manage those. And obviously, if the tube is being removed, you're toast. There's no way to fix that.
Should I be adding in baby aspirin to my daily supplements in my FET? Is Friday. Also, how close to my FET should I have intercourse to prime my uterus?
Every day for intercourse. And yes to the baby aspirin. Although everybody's different.
Very quick. Can Asherman syndrome be diagnosed by an HSG or a sono better?
Oh, a sono would be way better for Asherman's. Yeah, an HSG is not a good way to diagnose Asherman's at all. You want to see the infusion sonohistogram in 3D so we can see where the blockages are.
You ready?
This Pally person's quite entertaining. She wrote, I recommend aspirin after having kids too.
I'm constantly on it.
Yeah, Taurus got several children, so he would know.
You mentioned birth control is no good before an FET. I have endo. My doctor does suggest. Why is birth control not a good idea?
Because it probably increases miscarriage rates and failure rates. So in the endo population, it might be reasonable, but it's way better to do a suppression protocol, and birth control is not suppression. It's treatment or maintenance, but it's not like taking Lupron and Letrozole. Lupron and Letrozole are a lot more potent than taking the birth control pill is.
Hi, rock stars.
That's pretty cool. We got rock stars earlier too.
Yeah,
That's
that
nice.
means we're the real deal.
We're the real deal.
I'm wondering when we sign autographs. We'll just go with
A long time from now. Like maybe in 10 years when we're both decrepit, or at least I'll be decrepit. You'll still be good. You'll still be young and handsome.
You're very young and handsome. Do you think PGT abnormal embryos can self-correct?
Yeah, we know that PGT abnormal embryos can self-correct. The problem is we don't know when. And it depends on whether you're talking about placental mosaicism or actual inner cell mass mosaicism. So if you have abnormal cells in the placental tissue, it doesn't necessarily mean that the baby part of the tissue is abnormal. So that's the first thing to remember. The second thing is we know for sure that cells can kick out their abnormal chromosomes sometimes. That's been seen, but not at the blastocyst stage. Earlier, yes, but at the blastocyst stage, you'd be talking about hundreds of cells doing the same thing at the same time. They don't do that usually. So it depends on what we're talking about. I got a Candace Steed question.
Sure, of course.
What are the odds of 7mm follicles growing more to mature size by the time of retrieval? If they measured that size on Monday and retrieval tomorrow AM, 0. There's no way they would be big enough. Sorry.
Hi, IVF heroes.
That's pretty good.
That's pretty good. Never heard of that before.
We need a T-shirt.
I think that's a
you need
great...
to make. You need to make.
I think that's a good one, right?
Get some
IVF
T-shirts.
heroes.
Yeah. Fertility factor
if
fiction.
you like that.
Yeah, guys, thumbs up or likes or hearts or whatever if you think IVF heroes should be like a a badge or a T-shirt.
I think a T-shirt.
We could give them away.
We can give them away. I think people would like it.
That would be cute. Yeah.
Hi, IVF heroes.
Okay. One more time.
Yeah. 44 years old.
Yeah.
Moving to 26 years old frozen donor eggs.
Okay.
Do you recommend PGT in this case using donor sperm too?
No, definitely no. That would be a bad idea. Frozen eggs don't work as well as fresh. And so if you're using donor frozen eggs and then you're going to biopsy them and then you're going to refreeze them and then that's a bad idea. Don't do that. Yeah. And there's no indication in a 26-year-old. None. 0.
Retrievals in February.
Okay.
Can my husband and I enjoy drinks at Christmas time or limit to 2 drinks each?
Yeah, very, very little. Minimal to none would be best. Listen, alcohol is a class 1 carcinogen. Everybody knows I'm very anti-alcohol. In fact, we're coming out with an anti-alcohol video very soon. So I don't touch this stuff. I've never had a drop. I don't believe in drinking. I think it's literally pouring poison in your system. So I always put this very clearly for everyone. During this whole pandemic, what have we all used to keep ourselves safe? We used hand sanitizer and masks. So obviously the mask is irrelevant to this discussion, but hand sanitizer is very relevant. You are going to be using hand sanitizer to kill viruses and bacteria that land all over the place. How does it kill it? It kills it because it's basically 70 to 99% alcohol. What do you think it's doing to you when you drink it? It's just killing you from the inside out. Known carcinogen responsible for 4% of global cancer deaths. How does that make sense for anybody? It doesn't. It just doesn't. So I would avoid cancer, avoid alcohol like the plague. I'd avoid cancer too. I'd avoid alcohol like the plague. That's me. I get it. It's a huge part of the culture. If you need to drink or you have to be polite to your hosts or your guests, minimal. And I deal with this all the time. I go out with other physicians. There's always alcohol there. Never once taken a drink. And I don't care. If they're drinking, they're drinking. That's up to them. But do I want to put that stuff inside me? No freaking way. I'm off now. Good luck to you. And gotta say, I recommend Dr. Victory. You all have a great night. Thanks, Pally. It was good chatting with you.
That's good,
I love the real-time stuff. That's cute.
Hi, Dr. Vinti. We missed you at our egg retrieval on the weekend. It was neat to see those race cars in person.
Oh, cool.
What do you think about decreasing quantity of stims and increasing the time on stims?
I was here on the weekend. I wonder what weekend they were here. Increasing time on, okay, so decreasing quantity is always a good idea because high levels of gonadotropins is proven to be detrimental. In fact, we just reviewed that on our last show when we talked about natural versus stimulated egg quality. But in terms of prolonged, that's also really bad. If you go more than 12 days, your embryo quality is terrible. So never stim for more than 12 days.
Hi, Dr. V. I have an ultrasound done and it showed that I have 5.8 by 4.9 centimeter cyst on my right ovary.
Okay.
It said it is likely to be hemorrhagic cyst.
Yeah.
Does that have any impact on conceiving?
It does, because if they're saying it's hemorrhagic, it could also be an endometrioma, because some people think they're hemorrhagic, but it's actually an endometrioma. So if it's an endometrioma, it's going to have a huge impact on it. I would see a fertility specialist who can determine from ultrasound themselves if it's an endometrioma or a hemorrhagic cyst. Time would also tell. Hemorrhagic cysts shrink universally, but endometriomas don't.
To clarify my question about the RI after one miscarriage, it was a normal embryo. Would RI be worth checking?
Yeah.
Or do another FET and do it after the second one? If
no, if you've miscarried one euploid embryo, I want to know why. Now, it could be your partner. So again, like you do a DNA frag, he's got high DNA frag. Unfortunately, you're super high risk for miscarriage. So you don't necessarily need to like hit the brakes completely. There could be some basic testing to do to figure it out, but or just your personal habits. If you're a smoker and you're wondering why you're miscarrying, it's because you're smoking. So, it all depends on your whole history. I would need to know the details, but I like to investigate even after one euploid miscarriage because those embryos are precious, like super precious. I don't want to take any chances with any of them. That's just me. Other people would say, just keep transferring. And, some of the greats in infertility say, don't worry, don't do any testing. It's all meaningless. Just keep transferring embryos. That's fine. It's just not what I believe in.
My husband and I were recently referred to your clinic by our family doctor.
Okay.
While we are waiting for our first appointment, is there anything we can do in the meantime to facilitate the process and get the ball rolling on things? Also, what can we expect following our first appointment? 36-year-old female, 41-year-old, no children to date.
Welcome to VRC, first of all. I'm happy to have you aboard. So I would say that there's not a whole lot you can do other than live healthy, have lots of sex. If your weight's an issue, start dieting and exercise, because we will talk about that for sure. No smoking, no drinking, no drug use. Those are the basics. Aside from that, there's not a whole lot you can do. I've got my first appointment with you coming up. What should I expect? Thorough history, a discussion of possible causes, and then we're going to do a workup on you. And then once we've done your workup, then we go from there. My doctor put in my referral about a month ago. How long should I expect before hearing back? Probably in a couple of weeks. It was super busy because we had Health Canada here recently. So we were kind of backed up because of that, but you should hear within the next couple of weeks. How can I increase memory retention? Thanks.
Ginkgo bioma.
So there are studies that have showed that you can increase your memory simply by doing mind games. So mental exercise is actually really important for improving your long-term memory. So basically intelligence games actually do help. Aside from that, memorization is very helpful. So sit down and memorize things. That improves your memory processing as well. Beyond that, I'm not aware of too much, although I must admit memory is not my area of expertise.
Is it because you forgot?
That's funny. No.
That's funny, right?
Yeah.
Do thyroid antibodies increase the chances of a miscarriage? I'm 30 with no past pregnancies,
Yes.
but with endometriosis, treated with 2 months of Lupron Depot.
Yeah, thyroid antibodies do increase your chances of miscarriage for sure. So that can be a factor. That's been shown in so many studies I can't even list them all.
Did you get a T and V on there?
Did I get it? T&V? We did. It's our first TikTok T&V.
You gotta absolutely answer that question.
Okay, from does that say Manda? It's hard to see because it's on my keyboard.
keyboard,
Move it.
yeah.
Oh yeah, let's see. Manda. Yeah, there you
Manda.
go. T&V. Does high DNA frag have an impact on the outcome of a normal embryo after transfer? Yeah, it's a 1,183% increase in miscarriage rate. So it's huge.
Another good one.
Oh, cool. Michael Justin Haynot?
That keyboard's killing you.
It is. This might be off topic, but any advice for a current med school applicant? Yes. Amazing grades, lots of extracurricular activities. You need to stand out from the crowd. So demonstrate that you've shown leadership and you've shown a commitment to becoming an amazing doctor. Research is always beneficial. We like that. When you go in for your interview, you need training. So I definitely recommend you get some training. I'm happy to help you out. Just give me a text or a call or an Instagram message or whatever, and I will show you what to do. I've helped many students get into med school successfully, so happy to do that for you as well. There are tricks to passing the interview that are really important. The number one thing I would say, without divulging any secrets, because I am an examiner and interviewer for med school, is the key is to think through the questions carefully and give a very carefully rational step-by-step response. That's about all I'm allowed to say, but for sure, get in touch with me. Struggling a lot in physician assistant school due to memory loss and poor memory problems. I don't know what to do about that.
On the Nintendo Switch, there's a video called Big Brain Academy. Maybe
try Big Brain. That's Tarek's suggestion. Dr. T.
Yeah, there you
That's
go.
all I can say.
That's how we reference that
Dr. T,
information.
yeah. I would talk to someone. I mean, if you're in physician assistant school, you shouldn't be suffering from memory loss. So I'd want to know why. If you're using anything like marijuana, get off of that. That's terrible for memory.
You have one above that as well.
What would my suggestion be for weight loss in someone with a very healthy and active lifestyle? Weight's easy. It's terribly difficult to lose, but it's actually mathematically really simple. It's input and output. If you take in 1,500 calories and you burn 1,500 calories, you're never going to lose weight. And if you take in 2,000 and you burn 1,500, it doesn't matter what you do, you're going to gain weight. But if you take in 1,500 and you burn 2,000, it's impossible not to lose weight. It's literally impossible. So the key is to get your burn to exceed your intake. That's all there is to it. It's just calorie counting and exercise. It's pure and simple. Don't go on a treadmill for 4 hours. What you want to do really is build muscle. The more muscle you build, the more calories it takes to maintain the muscle. And so all of that energy goes into muscle maintenance, and so you don't store as much, and that's important. 9:05.
Oh, really?
And you're getting sleepy, buddy.
No, I'm good.
You are?
I'm fully here.
That's the first time I've seen you tired.
No, I'm not tired. What's the best way to increase blood flow to the uterus?
It sounded like a kid. I'm not tired.
I am ready.
What's the best way to increase blood flow to the uterus?
Yeah.
Acupuncture, aspirin, vitamin E, pentoxifylline, vaginal Viagra, human growth hormone, PRP. I'm missing one. Neupogen. All of those will be beneficial.
You just got another soccer ball on TikTok.
We've had soccer balls the whole time.
I think that the hearts turned into soccer balls.
Maybe I saw a couple of them. Ooh,
Did you see any hearts today?
I don't know.
I'm wondering.
It's kind of off to the side. I'm trying not to look, right?
You got another doctor. Hello, Dr. VNT.
Hello. Oh, SMBC. Cam. She was on the weekend with us too.
Yeah.
Hi. I'm looking at the wrong screen. Hi.
Crazy person waving the other way.
Yeah.
Do embryos that have been frozen and thawed and then PGT tested and frozen again increase rates in miscarriage?
Probably, and the success rates are decreased for sure. Yeah. No question.
Is it normal for a clinic to not test progesterone levels right after or before an FET or right after? Mine tested my levels before starting me on progesterone, but not after my transfer, which was on 12/12.
Yeah, it depends on what your clinic believes. So some clinics believe that the progesterone level before starting is important. We do too, because that's been clearly shown in 1,000 different studies. Some clinics believe that your progesterone level before you actually do the transfer is important because it should be in the right range. Other clinics say it doesn't matter. There is data to go both ways. I just feel that the balance of data showing that the level is important outweighs the data that doesn't.
Dr. V and the entertaining Mr. T.
Entertaining Mr. T.
They're good. They're good. These people are good.
They know how to get your attention for sure.
They got it, 100%.
Yeah.
Which vitamins do you recommend getting tested aside from vitamin D? Multiple chemicals, moving to a donor egg and donor sperm. Want to confirm nothing obvious is missed.
Just your ferritin and your B12. From a vitamin standpoint, iron and B12. That's it. And vitamin D.
Hi, Dr. VNT. You mentioned Neupogen as being helpful with egg quality. What is it exactly, and when does someone take it?
No, it's not helpful for egg quality. It's helpful for your endometrial lining. Human growth hormone is helpful for egg quality, and we started 2 weeks before and during the stim. Neupogen is good for the lining of your uterus. It's never been shown to improve egg quality. Not to the best of my knowledge, anyways.
Doctor, I'm 37 and my husband's... I have never tried to have a kid. How long does it take to get pregnant? I was waiting for an age for the husband, but it
didn't show up. Yeah. So 37 and then what? How long does it take to have a kid?
Yeah.
So 60% of people are pregnant in 6 months, 80% in a year, 90% after 2.
Okay. Hi, Dr. VNT. When doing second part of dual stim, why is it preferred to wait till the next cycle? And why is there a better chance of more embryos in the luteal phase?
Yeah, so what we found was that because we're trying to get most of your eggs in the follicular phase, there aren't that many left over for your luteal. And so I was telling people, why don't we just do what we now call split duostim, which is follicular phase this month and luteal phase the next month. So the reason we did that was because we get way more eggs, and that's huge. It's hugely huge. So we get a lot of great eggs that way, and we're getting like double what we were when we were doing true duostim, which is back to back. Does iron affect fertility? It totally affects fertility. There's good studies for that. Can low prolactin levels cause a person with high fertility to not be able to conceive? Not that I've ever read before in my entire life, no.
How do we make a virtual consult with you?
Email info@drvictory.com and ask for a consult. 5 more minutes? This show has gotten longer every year.
Sorry, man.
Like now we're going to 9, we used to be like 9, then we were like 9:05, then we were like 9:10. Okay, granted, like I love you, brother, and my wife is not around, so I got nowhere else to be, but till 9:15?
Someone said they will take an autograph, just for the record.
Okay, but you got to specify. Do you want Tarek's autograph? The illustrious, enchanting and alluring Mr.
Absolutely.
T. Or do you want my autograph, or do you want both? And I don't want to give anybody my autograph.
You know what?
I am not worthy of an autograph. This guy, he's totally worthy of an autograph. Me, it's worth nothing. Don't worry.
You know what the problem is with my autograph versus your autograph?
Yeah.
Your autograph, they can get meds. My autograph, can't do anything. Can't do nothing. Not even 5 cents.
Yeah, that's true. In the pharmacy you have in your head, maybe they could
Maybe,
get some.
maybe. There's quite a machine up here.
Yeah.
Hi, Dr. V&T. What would you recommend to synchronize your follicles? It's very difficult to read questions sometimes. I just want you to know.
Follicular synchronization is not helpful. You're better off doing duostim because all the techniques that are used to synchronize follicles actually decrease your response, like estrogen priming or birth control. So don't do that. The only people that can benefit from that are PCOS patients. Otherwise, don't do it.
Placental tissue is what Natria tests.
Natria?
Natura tests.
I don't know. I'm not sure what Natura is.
40 years old, AMH 1.8, all eggs were abnormal from antagonist stim cycle.
Okay.
Should I use donor eggs?
So you guys should watch our YouTube video, which is our currently most popular video, although rapidly getting close from that vitamin one, which is just bizarre
Everyone's
for
going
me.
bananas.
You did, you know, I worked so hard on that embryo math video. That's a great video. Okay, so embryo math, which is a video we have on YouTube. It's our most popular video, is super helpful for this, okay? So we're gonna do embryo math really quickly, like top-down version here. It's backwards math. So in order to get a genetically normal embryo at 40, you probably need 5 embryos because roughly 80% will be abnormal. So we're talking day 5, day 6 blastocysts. You're gonna need at least 5 in order to find one that's normal. So in order for you to get 5 embryos, depending on whose lab you're working with, you need anywhere from probably a minimum of, let's say, 6 to probably more realistic 10 fertilized eggs in order to achieve those 5 blastocysts, because most labs can only get you about half. Now some are higher, ours is way higher, but I want to give you like a relatively reasonable look at things. If you look at the literature, blastulation rates are anywhere from 30 to 70%. So the middle ground would be 50. So you need 10 fertilized embryos, like fertilized eggs, to grow into 5 blastocysts so that one is normal. In order for you to fertilize 10 eggs using ICSI in a top-notch lab, you need somewhere between 10 to 12 eggs. So you need to start with 12 eggs to get 10 embryos, to get 5 blastocysts, to hopefully find one that's normal. So you have to factor that math into your equation. One genetically normal embryo gives you a 50% chance of success, maybe a little bit higher in some programs, maybe lower in others. So calculate for yourself how many eggs you made and then figure out where you fall in that whole scheme. And keep in mind, it's a maybe. There are many instances in which you don't actually end up with any genetically normal embryos because it's an 80% chance per embryo. So I'm giving you like the really non-scientific math version of it. And in the video we talk about that. But the reality is that there's actually a decent chance that because it's 80% per embryo that you could end up with none. 1 minute. Last question.
Okay. So.
Oh, let's answer SMBC can.
SMBC, sure.
What is duostim? Why is it used? Okay, she wants both of our signatures, autographs, by the way. Thank you, SMBC Canada. Yeah, Tarek's ready. So duostim is when you do a follicular phase stim, so that's the first half of your menstrual cycle, which is traditional. And then you do one after you've released your egg, which is your luteal phase of your cycle. There is evidence supporting the concept that the embryos that come from the luteal phase are actually better quality than the ones that come from the follicular phase. So that's what a luteal phase stim is. And duostim is back to back, and we do a lot of split duostim now where we don't re-stim you until the next month. It's 9:15, time for Tarek and I to sign off. Do we still have tons of questions?
I love your banter.
You love our banter? I like our banter too. All right, thank you for joining us on another great episode of Fertility Fact or Fiction. We love you all. Thank you for all the likes. There were huge likes on TikTok, 654. Throw up more likes. It helps us. It's huge for us. So if you're still on watching, Lots of likes and soccer balls and whatever else. Thank you. We will see you again next week, which will be our final show for about 2 weeks until the new year, right? And then we will see you guys again in the new year for a whole new year of Fertility Fact or Fiction. Have a great evening. We love you all. Thank you for watching. I am Dr. Rahi Victory and my good friend Tariq Ibrahim. We will see you guys.